why do we need to vaccinate after transplant? I think the concepts here are that with the chemotherapy and or the TBI, or the total body irradiation, that is used to prepare the patient to accept the graft, that deletes many of the immune system cells in our body and can damage the immune tissues as well. We give a blood or marrow transplant subsequently, and that is to replace any remaining post-immune cells. But the bottom line, as shown in the cartoon in the middle, is that the immune memory, which is in the form of cells and tissues, is erased by the transplant procedure. And so who do we need to vaccinate? Well, it doesn't matter what type of transplant you've had, an allogeneic transplant and an autologous transplant. All of these patients essentially have to reboot their immune systems. And we do that after transplant by using about 15 different vaccines. And that's what we'll talk about. You might be interested to know that among patients who have survived 2 years after their blood or marrow transplant, vaccine preventable infections are 3 times greater than in the non-BMT cancer survivors and 30 times greater than in the general population. And this was a Fred Hutch study led by Amy Ford and Eric Chow from our center. Now, another study by the Center for International Blood and Marrow Transplantation Registry study, this is a very large population study with thousands of patients. It found that infection was a main or contributing factor to 30% of post-transplant deaths in greater than 2 year survivors. And older adults and anyone with chronic GVHD on immunosuppression had the greatest risk. And interesting, children had a 3-fold risk, even if they'd already discontinued all of their immunosuppression. So when do we start the vaccines? This is a little bit controversial, and the international guidelines that go back as far as 2009 and then subsequently revised in 2013, for the non-live vaccines, they stayed as early as 3 to 6 months post-transplant. And that guidance, it's important to remember, was based on expert opinion and literature that supported doing that when the circumstances were really ideal. And most US physicians prefer to wait for at least some laboratory signs of immune recovery. So it's not unusual that you'll have blood work to help guide whether 3 months, 6 months is really the ideal way to go. And the reason for that is in this cartoon that I developed with one of my vaccine colleagues from Children's Hospital, Janet England, there's so many factors that impact these national guidelines recommendations for time-based revaccination for all. And we don't really subscribe, in fact, most US physicians don't really subscribe to one-size-fits-all vaccination, because all of these bubbles in orange can affect and delay immune recovery, whether you had a full intensity transplant or a so-called mini transplant, that's the non-myeloablative. Depending on the age of the patient, some of their immune tissues can affect that. The thymus is a little gland that sits in the chest, and as you get older, that becomes less functional. Whether you've had a cord blood transplant or a marrow transplant, whether the graft has been manipulated in any way with T cells taken out in various ways, whether your tissue typing was fully matched or mismatched, whether you had a haplotransplant. And then on the post-transplant side, if you have active graft versus host disease, active infections, you could be on a bunch of immune suppressive therapy instead of including steroids. All of that can delay your recovery. So for this reason, we tend to not start vaccines before about 6 months in the ideal setting. And in terms of adults, most adults don't actually start their vaccines until about 12 months post-transplant. And our Seattle approach prefers to select for the early vaccination candidates for just certain vaccines if they're really, really doing well, as measured by these transplant questions here. If the patient's receiving any type of therapy, chemotherapy after transplant, they're not a candidate for the most part for early vaccines, with some exceptions. If they got some antibodies that deplete immune cells called B cells, these are things like rituximab. That's one example. If the patient has moderate or severe GVHD, that would be a reason to delay their vaccines. If they've had immunoglobulin therapy, usually that means that their immune system is not quite ready for the vaccines. then we tend to wait. And if they answer no to all of these questions, but they did receive immunoglobulin, then we would just check their immune cell levels, and that might allow them to get early vaccines, but generally not. So if the patient does happen to be eligible for early vaccines, they're really, really doing well, then we would give them a flu shot if it was flu season, and then we would just give them 3 vaccines, a pneumonia shot for Prevnar, Hib, and a meningitis shot. These ones are vaccines that tend to work better in people with a compromised immune system. So we can do quite well if we give them early under these ideal circumstances. So what are all of vaccines that we give after transplant? Well, I mentioned the pneumonia shot, and that's a little bit confusing in 2022, as I'll show you on some subsequent slides, because we have a number of pneumonia shots. Then there's the DTaP, or the diphtheria, tetanus, whooping cough, combined shot. The Hib meningitis shot, which comes in one form here, but then there's an optional form up here as well. And then there's polio, hepatitis A and B, the flu shot, and of course, now we have the COVID shots to consider as well. All of these are core vaccines recommended for our transplant patients. The ones shown on the right-hand side, the group B meningitis vaccines, the human papillomavirus, and the Shingrix to prevent shingles, those are under certain circumstances, which I'll talk about shortly. And then there's only really one live vaccine that we give now. It's either the combined MMR, measles, mumps, rubella vaccine, or that also can be combined with the chickenpox vaccine. And we'll talk about those. So if you add all of these up, patients get 24 to 33 shots, depending on what is appropriate for them after transplant. And they're generally given in the sort of childhood vaccination schema. Many of them are 2 months apart. Some of them are a little bit further apart, like hepatitis A, 6 months apart. And I don't have the COVID shot shown on here. That's got its own slide later on. So I'm going to, you can see the comments here, but I will talk about these on the subsequent slides in a bit more detail. So meningitis, why do we care about that? Well, in the US, this slide here from the CDC shows the incidence of meningococcal disease in the early 2000s. And it sort of peaks in the infant category, which is not so much applicable to us. But then you can see this peak in the adolescent young adults going off to college. And then there's this late peak in the elderly. So these 3 age-related peaks are what is shown on the left. And patients who are most at risk are those with a missing, either by surgically removing the spleen or having an abnormal spleen that doesn't work very well. And that is the setting of chronic GVHD, where we functionally believe, with pretty good evidence, that the spleen is really not doing its job as it should. And then there are some environmental exposures. So military recruits, college freshmen in dorms, and microbiologists that get to handle these bacteria need to be protected in particular. So we would basically recommend meningococcal vaccine, both of them, in fact, if you're in this group of environmental exposures. So both the Menveo or Menactra MCV4 vaccine, and then the Bexsero or Trememba, those are the brand names. That's the group B meningococcal vaccines, if you're in this category, and if you're getting chronic GVHD treatment where your spleen is not working. And so when you come to our long-term follow-up, we would recommend both of those vaccines if you fall into those categories. So the human papillomavirus, HPV9, some of you may know this as Gardasil, which is the brand name. Recommendations by CDC and the College of Immunization Practices are based on the fact that by vaccinating everybody who's age appropriate, we can prevent about 90% of HPV-related genital cancers and warts. So that's a very important statement. And it's routinely recommended in children starting at about age 11 or 12 through age about 26. But the ACIP actually extended this when the FDA approved this recommendation for the vaccine to be made available up to age 45. Now, because there are different risks in this group, then we don't automatically give it to everybody, but we sort of embark on what is shared clinical decision making. And so if you're an adult who's, say, 30 and you're on immunosuppression, for the most part, we would offer Gardasil or HPV-9 vaccination. There has in the past been some vaccine hesitancy, and that seems to be related to a lack of knowledge about its necessity and some residual safety concerns. But I think these little bullet points here give us pretty good reason to be not so concerned about safety. There's been more than 135 million doses given in the US, and the commonest symptoms are, like for many vaccines, local injection site discomfort in about 70%, some redness and swelling, occasional dizziness and fainting. This fainting is higher than expected in adolescents, but it's not really unique to the HPV vaccine, because it's also seen in adolescents with meningitis vaccines, MMR vaccines, and even the tetanus shots. Okay, my slide. Okay. Thought it was going to advance for a minute. So influenza vaccine, I just want to bring up a couple of things. You're familiar with this concept now from COVID vaccines, but before we had the pandemic, we sort of said the same thing. Having a flu shot won't prevent the flu, but it does really reduce the risk for hospitalization and deaths caused by influenza, and that is the primary focus. A single high-dose flu shot has been shown to be more effective than the standard dose, and this is in normal adults who are over age 65. And then in transplant patients specifically, there has been a double-blind study showing that one high-dose flu shot had slightly more injection site reactions, but it did give a better immune response. So, ideally, we would like to use the higher dose flu shots in immunocompromised adults. And recent pediatric data that's been submitted to the New England Journal, we're hoping for a favorable review, also shows similar findings. In this case, 2 doses of the flu shots, high-dose flu shots, produced better immune responses than standard dose, and like was seen in the adults, more mild injection site reactions. So flu shots are definitely recommended with the primary goal of preventing hospitalization and death. Now, I mentioned that the pneumococcal pneumonia shots were becoming more complicated, and this is because we have a new one that's available called Prevnar 20, and then we have some older vaccines that need to be put into context. So strep pneumonia is the full name of this bacteria, and there are over 100 different, the word is serotypes, but you can just think versions of it. And you may be interested to know that about as high as 90% of healthy people can have this bacteria isolated from their nose. And sometimes these bacteria can get into the bloodstream and cause pneumonia eventually, or even meningitis, and then there can be serious bloodstream infections. There are 4 current vaccines. The oldest one is now very old, in fact, almost 40 years old, called Pneumovax by Merck, and it covers 23 serotypes, but it doesn't stimulate long-term immunity, and I think eventually it's going to be phased out. And the reason I say that is because of this last points here. The 3 other vaccines called Prevnar stimulate long-term memory of the immune system, and they work better in immune-compromised patients. Now, we've been giving Prevnar 13 to many of you from all age ranges because it's been licensed as a 3 to 4 dose series in children and subsequently used in adults, and that's the regimen, that's the scheme we use in our transplant patients. Now, recently in 2021, Merck released their version of Prevnar 15, which covers 2 more of these serotypes, and Pfizer has Prevnar 20, which covers almost as many serotypes as Pneumovax. But it's only licensed, the Prevnar 20 is only licensed for adults at this point. The pediatric studies are ongoing, and the first pediatric study in around about 400 or so infants looks extremely promising, but it's not ready for the FDA to approve it yet down to that pediatric age group. And hopefully we'll see some news about that in early 2023. And I think once the Prevnar is hopefully approved in infants and children, I suspect we will see Prevnar 20 replace Prevnar 13 completely, and we will see Pneumovax likely go away. So summarized on this slide here, historically what we've given is a 3-dose series of Prevnar 13, which is the one that's currently available to all age groups. And I should have mentioned the reason that we haven't switched to Prevnar 20 in adults is because it's only approved as a single dose. So that's why we're still using Prevnar 13. And so if you get your 3-dose series of Prevnar 13, then that's why we follow up with this older vaccine to broaden that coverage to all 23 types of the pneumococcal disease that we're interested in. There are discussions underway whether we will replace all of this with the Prevnar 20, as I mentioned, and that's going to be contingent, I think, on whether those pediatric studies are lead to FDA approval. Now, if you chose to use the Merck drug, the Prevnar 15 vaccine, you'd still have to give Pneumovax because 15 is still about 8 serotypes short of the Pneumovax. But if you are a transplant patient who's had 3 doses of Prevnar 13 and you're an adult, then I think we are already at the point where we could replace Pneumovax with the newer Prevnar 20. So hopefully that's clear, but I think it's very good news because these Prevnar vaccines are much more effective than the older Pneumovax vaccine. So this brings me to another newer vaccine, the Hepatitis B vaccine. There's a newer one called Hepatitis B that's been around since 2017. And it hasn't really been used standardly in our transplant patients. We've preferred to stick with the older vaccine from the late 80s called Shingrix. But there are data to show that in normal patients who haven't had transplants, 2 doses of this newer vaccine are better than the old 3 doses of the standard vaccine. And there's a randomized study in kidney disease, chronic kidney disease, showing that 4 double doses of the vaccine that we're using in transplant patients is not as good as 3 single doses of this newer vaccine. Now, you may be asking, well, why am I talking about kidney disease? What's it got to do with transplant? Well, in fact, chronic kidney disease patients are quite immunosuppressed. So because the studies haven't been done, the necessary studies haven't been done in our transplant population, we use these kidney disease patients and then the hemodialysis patients with end-stage kidney disease as a kind of surrogate for us to extrapolate what is recommended for our transplant patients. So I think what we're going to be doing in the future is probably switching over to this vaccine as the default, the Hepatitis B. And until we do that, we would be recommending 4 doses of the double doses of the standard vaccine that we've been giving. So as I just sort of summarized, should this new vaccine replace the older vaccine? Well, 3 to 4 doses of this newer vaccine is likely to be better, but we don't have any transplant data yet. This newer vaccine is not licensed for children, so we can't use it in them. And the cost of 4 single doses of this newer vaccine is similar to 4 double doses of the older vaccine. So I think for adults, probably we could switch, but not yet for children. How many doses of Hep B vaccine are needed post-transplant? Well, it's 4 for the CDC, but really we should do a study in children and adults to be precise. And should the doses be single or double? Well, I think for the older vaccine, they should be double dosed unless the patient is more than 2 years off their immunosuppression. And the newer vaccine can be single dosed until we have transplant data that recommends otherwise. So I hope you're still all with me, paying attention. We've only got a few more slides to go, and then we'll open it up for questions. So the shingles shot, it's important to know that this Shingrix vaccine, that's been around for a few years now, is not a live vaccine like the old one. And the question is, who do we give it to and when do we give it? So if you had an allogeneic transplant and you're an adult over age 50 or 50 or and above, then it's definitely worth giving because shingles is more common in older adults. We wouldn't give it before 2 years post-transplant. And our policy is to give it at least 2 years post-transplant and at least 8 months off immunosuppression and not having any graft versus host disease flares. And it's a 2-dose series, with the second dose being given about 2 to 6 months after the first. Now, the reason that we don't give it before 2 years post-transplant is really nothing about safety. You can certainly give it early after transplant. But the problem is, if you give it before 2 years post-transplant and you are still on immunosuppression and taking a cyclovir to prevent shingles, we have no guarantee that vaccinating you with Shingrix will prevent you getting shingles. So that's why, if you can't stop your acyclovir, there's just not a lot of point in giving the Shingrix vaccine before we think you're able to stop your acyclovir. And stopping your acyclovir is very variable depending on if you have chronic GVHD and how long you're on immunosuppression. I think some of you may be familiar with being on immunosuppression for, say 3 or 4 years post-transplant and still being on acyclovir. So there's no point in giving the shingles vaccine because it might not work in someone on immunosuppression. That study, we can't really test very well in our allogeneic transplant patients. So in the autologous setting, we do have data to show that pretty much all adults can benefit from getting the shingles shot in allotransplant setting after 50 days post their auto transplant. And the second dose in that situation can be given about 1 to 2 months after the first dose. Okay, so here is a slide that sort of summarizes the key facts about COVID vaccination. CDC recommends extra doses for moderately or severely immunocompromised individuals relative to the general population. And stem cell transplant recipients who are within 2 years of transplant or taking medicines to suppress their immune system fall in this immunocompromised category. So if you think about that a little bit further, theoretically, that would mean we could vaccinate a transplant patient just the same way we vaccinate anybody else if they've been off immunosuppression and they're 2 years post-transplant. But I would propose that those patients are not all equal, because you could be 2 years and 1 week post-transplant and just discontinue immunosuppression, but it doesn't really make you like a general population person. And that's because you could have a flare-up of your GVHD and go back on immunosuppression. So I have, I call this my caveat, is that if you're also 2 years post-transplant and more than 6 months off immunosuppression, and with documented responses to all of the other childhood vaccines that we give, or at least good laboratory test data that shows your immune system's working well, then I think we can consider you like the normal population. But for the most part, our transplant patients continue to be considered in the immunocompromised category. So this is a slide that's I call a moving target. I update this slide all the time, and those of you that got handouts have a version that said 6/19/22. Well, just 11 days after I made this slide, the FDA approved the pediatric dosage, and then they also modified this 5 to 11. So I'm going to talk about the right-hand side first, assuming that most of you are adults and over age 12. And the primary series of COVID vaccinations is really 3 doses. And then after that, you get 2 booster doses. So the primary series you can see in more than 12-year-olds are 3 weeks apart, 4 weeks apart if you got Pfizer, whereas if Moderna, it's both 4 weeks apart. And then between that 3rd dose and the first booster, you want to wait at least 3 months. And between that second booster and the first booster, you want to wait at least 4 months. And it's important to note that Moderna boosters are half the dose, whereas Pfizer doses are full dose. If you happen to be a person who had a J&J primary dose, which is 1 dose, then the recommendation is that the boosters are actually either Moderna or Pfizer, and you would get 2 boosters 2 months apart. So for the pediatric series, if you're 5 to 11, it's pretty similar for Pfizer as it is for the older kids and adults, except there's just 1 booster. And if you got Moderna, There's 3 doses for the primary series, but no boosters for the Moderna at this time frame. And in the less than 5-year-olds, right now we're just giving 3-dose primary series for our immunosuppressed patients with no boosters. So happy to take more questions on that, but that's in a nutshell, COVID vaccination. Now, you often hear about concerns about side effects from the vaccines, and I think this data, I haven't updated it since April, but it's still fairly current. And if you look at the denominator here, this is 565 million doses. And the deaths that occurred, 14,000 is a big number, but when you vaccinate with this many doses, that's a lot of people. And so the death rate is 0.0025%. And that's just deaths without saying that they were related to the vaccine. And the attribution of these 14,000 deaths was unclear except for 9 cases that were associated with the J&J vaccine as a result of this TTS or thrombosis thrombocytopenia syndrome, so clotting and low platelet count. And even with the J&J vaccine, there's 60 cases of this rare, potentially life-threatening disease among over 18 million doses. And those 9 deaths happen to be a bit more common in younger females. With the Moderna and the Pfizer scenario, there are only 4 cases of this syndrome in about 544 million doses. So based on this statistically, there's considered to be no risk with Pfizer and Moderna for this syndrome. The risk of serious anaphylaxis, you can see, is about 5 in a million doses. The risk of another syndrome called Guillain-Barré syndrome, which is a sort of neurological syndrome that can be quite severe and can cause people to have respiratory failure. That's about 300 cases in over 18 million doses. And that tends to occur early, within the first 6 weeks, and has only been really reported with J&J and not with Pfizer or Moderna, at least back in April. And then you might have heard of some cardiac issues, inflammation of the heart or the pericardium, the little sac around the heart, myocarditis and pericarditis. There are about 2,300 preliminary reports, of which 1,400 have been verified in young patients under age 30, mostly male, adolescents and young adults, who tend to respond very rapidly and well to rest with symptomatic treatment. So again, even this syndrome is not that common when you consider how many doses have been given. So I think this might be near to my last slide. When to give the live vaccine, the MMR, to BMT patients. Traditionally, live vaccines were not allowed if you're on immunosuppression, so we haven't given measles, mumps, rubella until they're off immunosuppression, at least 24 months after transplant. And if they had chronic GvHD, we used to wait another 12 months after stopping immunosuppression. They cannot be receiving any relapse prevention medicines, with the exception of lenalidomide or baptizumab, which can be relevant to our myeloma patients, and not within about 8 to 11 months of receiving immunoglobulin. That can prevent a vaccine response in this case. And so before we had COVID pandemic, we actually had little measles epidemics, even as far south, not that far south in Clark County. And so that made us think about deviating from the rules. So it's extremely contagious. About 9 out of 10 exposed individuals become infected in the case of measles. Cases can be brought to the US from anywhere in the world with outbreaks in areas where people are under-vaccinated. We had declared it eliminated in the US in the year 2000, but there are about 1,300 cases in 2019, all linked to travel from about 31 states, and that had been the greatest number since 1992. And then what we saw during the pandemic was that US cases of measles plunged because of lockdown and masking. There are only 13 cases in 2020, and now they're starting to come up again, 49 in 2021. And unfortunately, due to COVID, 41 countries put off their 2021 measles campaign. So that leaves about 22 million infants who missed their first vaccine in 2020, about 3 million of them in the US. So we do foresee that there will be risk of larger measles outbreaks in the future, and we'll definitely be making sure all of our patients are vaccinated against measles if we can. And so I think this is my last slide here. Should we ever deviate from these rules? Well, in community outbreaks, the risk of clinical measles may outweigh the risk of vaccine-related complications. So we would consider on a case-by-case earlier vaccination if their patient is at least a year post-transplant, they have reasonable immune reconstitution based on their lab tests, and they're on limited immunosuppressive therapy or not on immunosuppressive therapy. And we have some data, not a lot, to inform that 1 to 3 is reasonable. And we follow the American Society for Transplantation and Cellular Therapy consensus criteria, which in fact we developed here in conjunction with our ID service led by Steve Kogan